So I am very excited to chat with Dr. Ami Kapadia as we are going to do a deep dive into the gut microbiome. We'll be chatting about the foundations of the gut microbiome, including fungi, protozoa, biofilm, talk about testing as well as treatment options. And so I'm going to start out by giving Dr. Ami's bio. And so Dr. Ami Kapadia has practiced as a family medicine and holistic medicine physician since 2005. She completed her residency at Thomas Jefferson University Hospital in Philadelphia and went on to work in varied settings, including an inner city urban clinic, VA hospitals around the country, and urgent care clinics in the Portland area. And she's been practicing in Portland, Oregon since 2015. Her practice focuses on digestive health and metabolic health, and she pays particular attention to the role of nutrition, lifestyle, and food and environmental sensitivities in helping patients reach their health goals. And thank you so much for joining us, Dr. Ami.
Thanks, Eric. Good to be here.
Yeah, glad you're here. And let's start out. I gave, of course, your bio, but if you could go into a little bit more background, how you just started focusing on the gut microbiome.
Sure. Yeah. My family's from India, and so I've informally been exposed to Ayurvedic medicine for many years, and then formally am doing some education in that as well. And sort of the gut is the root of a lot of our problems. I shouldn't say all, but most of our problems historically in some of the more ancient forms of healing, as well as now as we're learning more and more with integrative functional medicine and even in regular medicine about how so much of our immune system is dependent on our gut health. The gut-brain connection, the gut-skin connection, there's basically any issue you have, there's a gut connection component with autoimmune illness as well. And so it's one of the areas that we find is just foundational in helping anyone who's dealing with any sort of health condition help to improve their health. So even though they might have a thyroid issue or an autoimmune issue, mood issue, we're always going to think about gut health as part of how we can help them.
Yeah, definitely agree. And I think most natural healthcare practitioners, holistic practitioners, functional medicine practitioners, we all pretty much agree that you need a healthy gut for optimal health. There's that saying, all health starts in the gut.
Right.
And yeah, so let's, you mentioned foundations. Can you start by talking about some of the foundations and then kind of expand into like dietary recommendations that you give to your patients?
Sounds good. Yeah. And so, something that we sometimes forget to do if someone has seen a lot of other practitioners is just make sure that we aren't skipping over foundational aspects of what we all need to do for health. And so when I meet someone, I try to make sure we're not missing any of those really basic things and getting stuck on sort of fancy testing and other things where we've kind of missed the boat. So some of the things I try to make sure we touch on with everyone, dietary practices, the standard sort of anti-inflammatory diet, and that could mean different things for different people, but at least doing organic, non-GMO, removing added sugars, I think is really important. Meal timing, I think, is important, just not sort of eating continuously all day and into the night, having some spacing of meals, which again is sort of like a tradition in Ayurvedic medicine, as well as now as we've learned about more with our migrating water complex and all of those things. It's important to give our digestion time to work in between eating. So those are some of the foundational nutritional things that we go over. And then of course, stress in whatever management we can do. Everyone's under way too much stress. So not forgetting about the effects of that, outdoor light exposure, exercise, sleep, all of those foundational things are really important to make sure we're going to get the sort of most bang for our buck in any digestive protocols that we're doing. So that's where we start with a lot of patients and making sure we're, again, not having artificial sweeteners and chemicals and all of those things as best we can.
Can you talk a little bit more about meal spacing? Because I know you mentioned migrating motor complex, and if someone has SIBO, like small intestinal bacterial overgrowth, I know that a lot of practitioners recommend going like 4 hours in between meals. And obviously, when you sleep, you're going to go hopefully at least 8 to 10 hours. But do you think just in general, even if someone doesn't have a condition such as SIBO, that they should go a number of hours in between meals?
I think it makes sense. And I think we sort of did a disservice to patients. There was this trend of telling people to just eat snacks all day and I think it's one thing if they have hypoglycemia, of course, they need a different type of a dietary intervention. But for anyone who doesn't have hypoglycemia or having low blood sugar symptoms frequently, ideally they're having like a couple main meals, maybe a snack if needed, and trying to not eat overnight for at least 12 hours, I think is what's been found to be, even with Dr. Bredesen's work with dementia and things like that, giving our system a break overnight helps with things like autophagy and, just all of these processes that we're learning more and more about that historically we would recommend people would do that, but we didn't have all the science. And now we have more and more science about sort of intermittent fasting and all of these things. But I try to keep it simple. So 12-hour overnight fast is great. We just don't want to be eating up until the minute we go to bed and then eating first thing in the morning. So if you can stop a couple hours before bedtime, that usually can get you a 12-hour overnight fast. And then trying to have a couple regular meals and not just kind of snacking throughout the day, I think is good for everyone in general, outside of if you don't have things like SIBO and overgrowth and such.
So even if someone is incorporating, let's say like a 16-8 fast, and for those who are not familiar with it, just going like 16 hours fasting, have an 8-hour eating window, you wouldn't recommend continuously eating during those 8 hours. You would still kind of space it out, maybe just have a couple of meals. And
I think that would be better, just traditionally sort of what's worked well for our digestion, as well as some of the newer information we're finding. I think they'll still get that overnight fast benefit, but it makes more sense to sort of have a couple regular balanced meals than just to be eating continuously, ideally.
Getting back to I guess sticking with the diet, but talking more about elimination diet, because I think I could be wrong, but do you do both elimination diet and incorporate food sensitivity testing, or do you essentially just start everybody off with elimination diet?
I do both. And so, for everyone, I do the normal gluten antibodies that you can get through Quest or LabCorp because it's an easy screen. For some patients, I do advanced gluten sensitivity testing, but not everyone. And then beyond that, outside of removing added sugars, I give patients the option. Elimination diet is really the gold standard, but it's hard to implement. So it's challenging with the busy lives that everyone has. So that my favorite book for that is from Tom Malter, and it's called The Elimination Diet. I believe he and his wife put together that book. And it's just I think it's a good, at least one time in your life sort of thing to do to get a sense of how food might be affecting you, if that's possible with your lifestyle. If someone can't do that, ideally we'll do the gluten sensitivity testing, and then we'll try to remove one or two of the more inflammatory foods, specifically cow dairy, along with sugar, at least those couple things, to see if we can reduce inflammation. But and the food sensitivity testing, I think, can be a useful tool if someone isn't ready to go into an elimination diet. It's certainly not 100% accurate. It has false positives and false negatives, but it is a tool. So we could use that sometimes to help motivate someone to potentially try an elimination diet. And so, gluten, dairy, soy, egg are some of the most common food sensitivities we see, but usually someone does not need to avoid all of those long term. We can find the couple that are irritating their system.
Yeah, I agree with the flaws that, I mean, really, there's no perfect test. Even like
Right.
stool testing, we could say there's, like someone could test negative for parasites, but still have parasites. And so with
Right.
food sensitivity testing, but is not exactly the same. But as you said, you could have false positives, false negatives. That being said, do you typically, when you recommend food sensitivity testing, is it IgG food sensitivity
It's
testing?
IgG, and there's I don't know if we want to say specific. I don't have any affiliations, but
Sure, you could name the lab. Yeah.
it's a cost effective through Alitas. It's a 95, I believe, IgG food panel for like $120. So it's quite affordable. And again, it's like a good overall, where for some people, I think that they might have a lot of food sensitivities, and I'm getting like a completely negative panel. So it does help me kind of, even though we might still explore that because it's not 100% accurate, it does lend itself some information to the overall picture of what we're dealing with. I know we're not going to dive into this, but this whole mast cell histamine reactivity in the gut can look like food sensitivities when it's not. So that's another whole topic that we can talk a little bit about if we get to.
Okay, yeah, that sounds good. How about nutrient deficiencies? Can you talk about
Right.
some of the common nutrient deficiencies you find?
Yeah, so again, through sort of routine lab work through Quest or LabCorp, I routinely will check zinc, copper, ferritin for iron stores, and B12. And I frequently find low or low normal levels for zinc, B12, and ferritin for a lot of my patients. And so that's another sort of easy screening to look for nutrient deficiencies. Some people, again, even though they've been to lots of practitioners, and have tried lots of things, surprisingly will have some benefit from simple nutrient repletion, more so for B12 or iron. With zinc, I don't have people notice sort of immediate improvement, but it's one of the things we replete just to help in their overall healing. But with the other ones, sometimes people do have a noticeable improvement in their symptoms.
For B12, do you recommend serum B12 or methylmalonic acid?
You know, I've had good luck with just checking a regular serum B12. And if it's less than 400, certainly consider repletion. If it's less than 600, we sometimes will still consider improving, optimizing levels. But yeah, I often find low normal levels with that. So I don't always do the methylmalonic acid unless I'm digging further.
Okay, great. And then for zinc, is it serum zinc? Is it RBC
It's
zinc?
plasma zinc, so plasma zinc, serum copper. There's a reason that intracellular zinc is not as accurate. One of the sort of founders of functional medicine had given a talk many years ago, and I never fully remember all the details, but it has to do with an intracellular enzyme. So intracellular zinc, I've been taught is not as accurate. So I just go with, again, the blood levels, plasma zinc, serum copper. Hopefully that's what I said before. There's now,
I
that
think
being
so.
said, when we order it through Quest, I can't always get the one that I want, and it still seems generally accurate with whatever they're running for us. So I order it as such, but it's been a helpful guide.
Do you ever look at, I mean, I'm sure you do a conference and metabolic panel and the basics of CBC,
Right.
but some will say that if alkaline phosphatase is low, like less than 60, that could indicate a zinc deficiency. Do you?
Yeah. I've learned that too. I can't say I've always seen it correlate though. And I do usually have a hepatic functional panel and a zinc level. So I typically do both because I don't always see it correlate.
Okay, that makes sense. So can we talk about microbes now?
Sounds good.
All right, so you know I want to talk to you about fungi and protozoa,
Right.
maybe even H. pylori if we have time. But can you talk about opportunistic bacteria? Like, I guess I should ask you first. Do you typically do like a when you do testing for the gut? Do you do like a comprehensive stool test?
So I typically, when I'm doing stool testing, we'll talk about blood markers I use for Candida, but for stool testing specifically, I'm usually looking for protozoa.
Okay.
I'm not fully convinced that the technology we have for stool testing is giving me the best picture of bacterial imbalance if and when it's there. And I kind of assume everyone has some bacterial imbalance. And so part of the treatments we use are broad spectrum botanicals that hopefully will be helping to resolve yeast imbalance and bacterial imbalance when it's there. I think the stool testing we have can be helpful, but my go-to is a particular, I use a para-wellness stool testing, which looks more at, I'm looking at identifying protozoa because it's one organism which I feel like we can treat and kind of move past, whereas these yeast and bacterial imbalances can sometimes be a longer sort of treatment plan to help rebalance over time.
Yeah, and I will add, and I tell patients this when I don't do stool testing on every single person, but when I do a comprehensive stool test, almost always we're going to find some type of dysbiosis, some type
Right.
of imbalance in the gut flora. So very common to see streptococcus and staphylococcus, and sometimes Klebsiella pseudomonas. And even if we put someone on a treatment protocol, it's not like their gut's going to look perfect. There's still going to be imbalances. So I think that's a good approach to not go crazy and just do testing on everybody and treating everybody for opportunistic bacteria. So, but yeah, I just wanted to pick your brain.
Right. And it's, it's tricky because if we see it, we know it's there, but we still don't know if it's causing the person's symptoms. So it's always sort of like, is it worth doing an intervention for that? We'll get into protozoa, but even, for example, patients with Giardia, some of the studies show a significant number of people just have Giardia and they don't have any symptoms, and other people are incredibly symptomatic from it. So it's always like this weight of, okay, are we going to test? And if we are going to test, are we ready to do a treatment? And what are the risks and benefits of subjecting someone to that treatment?
It's funny you mentioned that. I actually had someone test positive for Giardia, and I was asking, are you having are you having like diarrhea, gastrointestinal, any type of gastrointestinal symptoms? And she wasn't having anything that would indicate she has, like a Giardia infection. So I was also, I forgot where I heard it, but where you could be like a carrier for,
Yeah, and
Giardia or Salmonella also.
right. And with Giardia, it's tricky because if someone's had it for a long time, some of those patients I've had have much more chronic constipation, and we of course learn about it as causing acute diarrhea. So it's tricky to know exactly what's doing what sometimes.
So let's talk about fungi.
Okay.
So what's the consequences of fungal overgrowth? Because I mean, fungi by itself isn't bad. We want to have yeast, just we don't
Right.
have too much of it. So if you could dive into a little bit of
Yeah.
fungi.
So the way I typically explain it with patients is with our microbiome, there's protozoa, bacteria, yeast, and some of these other archaea and such. But those are the three primary organisms we're sort of working on. And there's usually some combination of those being out of balance. The sort of consequences of if yeast is out of balance, it can cause quite a bit of digestive symptoms as well as systemic symptoms due to the whole sort of breach of the leaky gut, and sort of causing symptoms in other organ systems, such as symptoms that sound like allergy or skin reactivity, brain fog, as well as sort of common IBS symptoms. So the symptoms that patients can get are very similar to SIBO. And so again, it's tricky to sort out, is this from bacterial overgrowth? Is this from yeast overgrowth? Is this from a chronic protozoal infection? So we talk about trying to work with whichever of those is the most easily identified and goes along with that person's history, and then kind of reevaluating, seeing where we are with that. So I do test for that frequently with, again, just standard blood markers through Quest. I check a Candida immune complex and antibodies. And while it can't prove that someone has an overgrowth, it gives me clues and puzzle pieces. If those, particularly the IgG to Candida or the immune complex, are elevated and they're having gut symptoms or a lot of systemic reactivity that we talked about, it may be worth doing a trial of anti sort of yeast medication or botanicals. And the advantage of using botanicals, like we talked about, is that they can work on other organisms as well. And we can see where we are after that. And I know we're going to talk about protozoa as well. But if I find both, I typically will treat protozoa first, just because I find a higher success rate of treating that over the short term with pharmaceuticals usually. So we can kind of get that treated. And then again, the sort of yeast imbalance, bacterial imbalance can be a longer term proposition. So we usually have to spend more time with that.
Okay, so protozoa you treat first, and it sounds like I think you said for that you don't use botanicals. Usually, you go to the pharmaceuticals like
Yeah.
metronidazole, for example.
So I typically, if someone has, for example, the most common ones we find are Giardia and Cryptosporidium. If someone has one of those, always important to remember, I have them filter their water to make sure we're not having re-exposure. And then for treatment, I do typically use pharmaceuticals unless they prefer botanicals, just because it's usually just a couple-day treatment. And I use tinidazole more than metronidazole. It just seems to be better tolerated, and it has quite good efficacy for Giardia as well. For Cryptosporidium, there's no perfect medication, but nitazoxanide can work well for that. In conjunction, for that one, I do use botanicals as well, because there's no pharmaceutical that's anywhere close to 100% at eradicating that, as far as I know. So I'll sometimes do nitazoxanide pulsed with some botanicals, and then a second round of nitazoxanide, and then more botanicals for that one. With Giardia, it has pretty good success rate with standard pharmaceuticals, either metronidazole, tinidazole, or nitazoxanide. I would say tonadazole is my go-to that I start with just based on my preference.
Okay, I definitely want to get back to the fungi, but what's your thoughts on Blastocystis hominis? Because
That's a
there
good
is some,
question.
yeah.
Yeah, I've sort of wavered over the years. And on my website, there's a section on protozoal and parasitic infections where I've tried to list some of the studies looking at what we can use for eradication. But the first question is, should we even be trying to eradicate this? Is it causing problems? So there are studies showing that if someone is symptomatic with IBS, eradication of Blastocystis hominis can improve symptoms. So for someone, it's not my first priority to go after that if someone has that and other things. But if we've done other treatments and they're still symptomatic, I think it's worth a trial of treatment. I used to do a longer course of nitazoxanide for that because there were studies on that. And then I found that shorter courses had almost the same eradication rate. And I don't love putting someone on pharmaceuticals for any longer than we have to. So I do sort of my standard Cryptosporidium 3-day nitazoxanide treatment now, repeated 2 weeks later if we are going to use pharmaceuticals. There are also botanicals that can work for that. Some of the standard ones that we use for protozoa, Artemisia, Berberine, things like that can be helpful. So sometimes I'll do a combination treatment like I do for Cryptosporidium. I'm not convinced it's causing problems for everyone. It's so ubiquitous. But again, if they've treated a lot of other things, we definitely will talk about, do we want to try to treat this and see if they get symptomatic improvement?
If there a situation where you're just focusing on the protozoa and let's say the person just wants the botanicals, like, you just mentioned, how long on average, like, is it something that you mentioned the medication, the advantage, you could knock it out in a few days? Are we typically looking at a few weeks, a few months when it comes to protozoa and botanicals?
Yeah, for protozoa, so it is rare that I just use botanicals, but if I do, I'll usually do at least a month or so, and then we'll kind of see where we are with treatment. And in addition to, so again, I don't have any affiliations, but I use a lot of Supreme Nutrition products, and they have Artemisia Supreme, Mimosa Supreme, Malia, which is neem, and they have a berberine, which is Coptis Supreme. So I don't use all of those by any means, but I'll pick one or two. Beyond Balance also has some really nice protozoal treatments that are very safe for kids and adults. And so I'll typically pick one or two, do a bottle of that and see how they feel. I don't like to just continue it for longer than that. We usually will pause if they're doing better and see if we need longer treatment, and kind of gauge their symptoms before proceeding with more than a month or so of treatment.
Okay, great. Thank you for sharing that. And so getting back to the fungi. So if someone, I guess, have you seen where someone does have a yeast overgrowth, yet the antibodies are negative?
Yes, so there's no perfect test for it. So often patients will come in with a stool test or these blood markers that I'm talking about. And I try to remind them, we still don't know if this is causing your symptoms. So we want to stop and reevaluate each time. But whatever yeast overgrowth someone has is not going to be sensitive to all of the botanicals or all of the pharmaceuticals. So just because we treat it and it doesn't improve, we could either be using the wrong agent for what they have, or we could be on the wrong track. So I typically will try 2 or 3 different things if we don't get a response with the first intervention that we do before giving up on yeast overgrowth as a piece of what's going on for that person.
And what do you think about organic acids testing, like looking at arabinose and some of the
Yeah.
other yeast markers?
Some of my mentors used a lot of that and I like it. I couldn't find a lot of research backing up that usage outside of the companies that offer it. So I think it's another helpful tool. If someone has done it, I can use that information. If those are elevated and I have elevated immune complex and it's showing up on a stool test, again, while none of those are definitive because we all have yeast in our stool, and there's no concentration level that indicates an overgrowth, putting those pieces together gives us more clues as to, okay, it might be worth going after this,
All right. And then another question when it comes to, we're focused on the gut here, but how about other types of fungi? Like if someone has like toenail fungus, would you treat directly to toenail, or would you still like, is the root cause still the gut in this
I've
example?
seen that be its own thing a lot of times. So when I've worked with veterans, for example, if they had to wear boots a lot and they were sweating a lot, that could, just the conditions of external moisture can be there. Other people, I think there has been shown to be a genetic component for just your body having what I just generically say trouble controlling yeast and fungi. And so I don't see toenail fungus to be necessarily correlated to any sort of internal issue. Of course, it could be, but I tend to treat that specifically, usually with pharmaceuticals, the standard protocols, as well as some compounded topical antifungal prescriptions that we can get from our compounding pharmacy. And that's worked well for a lot of our patients.
How about vaginal candidiasis?
So that I do see that often having the person also has a gut imbalance. There's also been some studies showing some women are genetically prone to getting that, because we've had some patients where they've been on so many antibiotics and they never get a yeast infection. Other people, they go on one course and they get this recurrent problem. So I think with those patients, I do often see that there's a GU component and a GI component. So we're working on sort of this full spectrum treatment that we're talking about.
All right. And then with the treatment, so again, you're more likely to use botanicals with the fungi than the protozoa, but there are times when you recommend the antifungal meds. So could you talk about like when you would use nystatin versus like diflucan?
Right. So if someone hasn't responded to botanicals and I'm still wondering, do they have a fungal imbalance in the gut? I'll typically start with nystatin. It's not systemically absorbed. It's very safe. And the benefit it acts on the mucous membranes that it hits. So if they have like a oral or esophageal issue, you can actually you can get compounded nystatin capsules, empty that in water. It doesn't taste good, but you can swish and swallow that. And if you're doing just the capsules or the commercial tablets, that's going to act in the gut where it's hitting. So it's not systemically absorbed again, and it's really concentrated in the gut imbalance area that we're trying to treat. And so that's usually where I start. If I've done that and I'm still not sure if they have a problem with yeast because we haven't had a clear response, it's possible that the overgrowth they have is not susceptible to nystatin. So sometimes I'll do a couple of weeks of fluconazole. I don't like to do that long term. It has a lot of drug interactions, and I think using it on a broad scale for a lot of patients with digestive disorders isn't a great idea, given we don't have a lot of good antifungals and this whole resistance issue. But I'll sometimes do a couple-week trial, and if we get a really good response, I'll try to find some other agents that'll be helpful for them, but it can help us decide if we're on the right track or not.
All right, that sounds good. And then I know you mentioned botanicals for parasites. Did you mention like what you like for yeast as far as
Yeah, for
botanicals?
yeast, so the good part again is that some of them overlap. So I find Berberine or Coptis to be really helpful for bacterial overgrowth, yeast overgrowth, and protozoa, depending on the person. The other ones I frequently will try, neem also can have effect on all of those. Undeslinic acid is another one. Thorne makes a product that's been around for a long time. So that specifically I'll use for yeast a lot. And then Beyond Balance makes mycorrhizin, which I'll also use for yeast a lot as trials of more yeast-specific therapy. So those are some of my favorite 4 or 5 that I use. Olive leaf also can be really helpful.
Okay, I was actually going to ask you about olive leaf, which I know also could help with viruses and other things too.
Right.
How about oregano?
One of my mentors just was not a fan of oil of oregano just because it's so strong. I've had patients where they've told me it's been quite helpful, and if it's helped them in the past, we'll consider using it again. But I think just my personal bias is I don't use it as much because of personal teachings from one of my mentors. I don't think it's wrong to use it. It is very strong, so I would just not use it for a prolonged period of time.
Yeah, I agree. I mean, it's good to at least briefly mention that some of these could have a potential negative, like just because it's natural doesn't mean it's completely
Right.
harmless. Yeah, arguably it's better than taking an antibiotic, but still, like you said, you wouldn't want to be on like oregano oil for 6 months if you're going to take
Right.
it.
And some of
Probably
the
short.
patients were, before I learned about mast cell activation and histamine reactivity, I was treating them with botanicals over and over and it was helping, but it didn't seem like that was the root cause. And so again, if we're treating someone over and over again and they tend to improve but not fully and it keeps coming back and all of those things, we'll talk about how we can go after the biofilm issue because sometimes that's the problem, but also sometimes it's this mast cell histamine reactivity in the gut, which can really mimic the symptoms of any of these abnormal gut flora issues with diarrhea, constipation, bloating. And so sometimes it's worth a trial of very simple H1, H2 blockers to see if that helps. And sometimes that's helped a lot more than any of the sort of dysbiosis protocols I've done. We just have to remember to think about it, as part of our differential. If someone's having ongoing gut and other symptoms, that might be another avenue to treat, in addition to looking at biofilms causing resistance.
And is that, yeah, definitely want to talk a little bit about biofilm, but with the mast cell activation syndrome, does that relate? Because you mentioned earlier how someone might have not food sensitivities, but they might have, mast cell activation syndrome or histamine intolerance. I know
Right.
they're not exactly the same, but so is that kind of what you were talking about just now as
Yeah,
well? Or?
it's this whole sort of spectrum of disorders, specifically for gut health, but also allergic and skin conditions and all sorts of issues where it wasn't in my differential until the last 5-6 years. And so I was missing it. But there's mast cells throughout our body and they contain histamine and all of these other mediators. And it's been found in patients with IBS that the mast cell reactivity is higher in the gut compared to other patients. And so it may be that they're just having this overall sensitization and reactivity as opposed to like, I'm reacting to egg, I'm reacting to dairy, I'm reacting to soy. It might just be whatever they're eating, their gut is just hyper reactive. And so just calming that down can help prevent having to restrict their diet as much, And so it's something to think about. And some of the sort of most effective treatments, if it works for the patient, things like cromolyn. Some patients it doesn't do anything. And I've had other patients where it's like 75% reduced reactivity of foods and such, not because they were reacting to all those foods, but because their histamine reactivity is up. And then the tricky part is what is causing the histamine reactivity and mast cell reactivity. And that's all of those things we're talking about. These gut bugs can do it, food sensitivities can do it, stress can do it. So we still have to go digging, but it can certainly help stabilize symptoms so we can buy ourselves some time and improve quality of life.
Yeah, so definitely agree. You want to address the cause of the problem. So if so you said H1, H2 blockers, and as you just mentioned, you don't want to just give the H1, H2 blockers. You want to do things to address what we're talking about and make sure it also incorporate diet and lifestyle factors. But I'm sure there might be some people listening who are wondering about quercetin. Can I just take quercetin instead of like the H1, H2 blockers? And I'm guessing it's probably not strong enough in many cases of mast cell activation syndrome.
The conclusion that a lot of us have come to, that a lot of us do prefer natural botanical food-based interventions, but in my community, what we've found is that the natural agents, we can kind of circle back around to them, but we're not getting as clear or definitive of a response. So if we're really trying to figure out if this person is suffering from mast cell reactivity, we've just had a lot more success using pharmaceuticals, at least for a 3 to 6 month trial. And then we can say, okay, this is helping or not. And if the person prefers botanicals, we can always try to regroup and go that route. But I haven't seen those same results with quercetin, for example.
Okay, great. Thanks for letting me know, or letting us know, letting the audience know. Uh, one thing before we get into biofilm, I do want to ask you, getting back to, we spoke about oregano being a little bit harsh on the gut microbiome. What's your thoughts on berberine? Because you do mention berberine, and
Yeah.
I've interviewed one specific practitioner who wasn't too high on using berberine, but then the more recent research seems to show a beneficial effect with berberine in the gut microbiome.
I know, and that's sort of gone around and around with, because we have some patients where we are using botanicals more long term, and I would love to know if there's any studies showing that it's causing disruption of the microbiome. I remember like one of my first integrative medicine conferences, like 15, 20 years ago, I asked the speaker who was talking about berberine for blood sugar, well, are you worried about using this long-term with patients? And he was one of the most well-known senior doctors. And he's like, well, we monitor, but we haven't seen it. And so it is strong. I don't like to use it for indefinitely, but I have not personally seen negative studies I haven't seen studies showing it has a negative effect on the microbiome, and there have been studies showing it has a positive effect on the microbiome, and it helps blood sugar. So maybe we wouldn't use Coptis long term. That has, I believe, stronger activity than some of the other berberine containing herbs, but I have not seen data showing that we're causing a disruption. And I clinically, from my Chinese medicine colleagues, I've learned it's sort of a cold forming herb. So I'd be cautious with using it with certain constitution of patients. But I haven't seen data on negative effects.
Okay. All right. Well, thank you for sharing that. And let's talk about biofilm. So when do you use biofilm, and what's some of your favorite biofilm disruptors?
Yeah, so some of my mentors have had very drastically different views on biofilm. And some of them, again, like dating back 15, 20 years, some of them said, don't mess with biofilms. They're there for a reason. It's our body's way of sort of walling off things. And I've had other mentors have the opposite view. And I'm sort of in the middle. I don't start with biofilm treatment. I think we do have to be cautious, especially with someone who's had symptoms for a long time. That being said, I don't give it with the first round of treatment, but if someone is having non-responsive symptoms or recurrent symptoms, it's definitely one of the things we think about. Do they have biofilms? And that's why the agents we're giving them, whether pharmaceutical or botanical, are not getting to where we want them to go. And so I will introduce biofilm treatment cautiously. And we usually use it, Dr. Paul Anderson has some really good information on some of the products he's formulated. There's some over the counter and some prescription ones. And I typically start with over the counter. Some of the ones I've used more so are some of the enzymes like lumbrokinase and nattokinase, as well as Priority One. Again, I have no affiliation. They have a biofilm, I believe it's called Biofilm Phase 1 or something like that. They have a product that I found helpful. Those are some of the ones I'll start with. If we're still not getting to where we want to be, and it seems like the patient was tolerating those, but we just didn't get anywhere, and I want like a yes or a no answer about our biofilms part of what's going on, we'll use the prescription compounded version that Dr. Anderson formulated and that various compounding pharmacies use. And it's a sort of a bis-thiol complex that's quite strong, but that will give me an answer. If someone has an exacerbation of symptoms or improves, then we know that biofilms are part of why they haven't responded. And so you want to start them on that complex and then have botanical support on board, because if we are opening up these biofilms, we want to make sure we're helping to treat whatever is in there, whether it's protozoa or yeast or bacteria or whatever else might be part of that biofilm community. So typically we're looking for some sort of response. Did they get worse or did they get better on the biofilm treatment, as opposed to just, I took it for a month and I didn't feel any different? Then there probably isn't a biofilm component to why they're not responding.
Yeah, you mentioned Dr. Paul Anderson. So I don't know if you heard this, but a number of years ago, he mentions, I mean, he might mention now too, but I heard a few years ago where he spoke about taking a biofilm disruptor before, like 7 to 10 days before doing a stool test, just to reduce the chances of getting false negatives. So I'm thinking you're probably not doing that with the Power Wellness, but I don't know if you heard him talk about that.
I have, and I used to do that with certain stool tests. I think with the Pair Wellness, I get so many positives as is. I haven't needed it, but if I do, like if I have a patient that prefers a different type of stool test, I do think it's a good idea, because they are probably not looking themselves under the microscope like the director of Para Wellness is actually looking microscopically, whereas there's different technology being used with some of the other stool tests. And so I think it's a good idea. We do typically, I think it is like a 7 to 10 day protocol, and then you collect your stool after that, unless you have an aggravation of symptoms, and then you just stop it and collect your stool sample.
Okay, and what are your thoughts about NAC as a biofilm disruptor? It's not just for that purpose. A lot of people take it, including myself. I recommend it for supporting glutathione, a precursor of glutathione, but also in some cases can be used as a biofilm disruptor.
Yeah, I think it can be useful. I would say it's not strong enough to give me a yes or no answer, but I think if you were using it as one of those initial ones to see if there's a sort of gently get into biofilms, it's a good idea. I still hesitate to use it long term because there's healthy biofilm communities, but I do find it is useful for, if someone's having a respiratory infection, we're trying to thin secretions, or like you said, precursors. I think it can definitely have a role. I tend to avoid using it longer term, just for theoretical risk of disrupting healthy biofilm communities.
So I'm glad we're having this conversation because I do commonly recommend NAC. Would you then tend to, if you're trying to support detoxification, would you tend to go more towards like a liposomal glutathione because of what you just mentioned, or?
Yeah, detoxification, that whole topic, I think I used to do very complex protocols, and I've kind of gone back to more simple things again. So some people feel amazing on acetylglutathione or liposomal glutathione. I've had an equal number of patients that don't feel good on them. So I don't think it's essential to use. I think it can be helpful. And so we'll try it if we're trying to do a very targeted detoxification treatment. But I've gone back to sort of trying to ensure someone's having good elimination, using food forms of fiber like psyllium, chia, flax, just to get bile binding that way. Sauna therapy, if they tolerate it, outdoor exposure. But if I am going to do a targeted detox protocol, I think what you're doing sounds really good. Trials of NAC or glutathione, but maybe just not using it as longer term. And if with the glutathione, just letting patients know some people feel better and some people feel worse. So let's see how you do. But I start with sort of those more minimalistic interventions, and then I see, do we still need more detoxification support after that, particularly if someone can't sweat or can't do a lot of movement. Then I think everything you're talking about definitely can be part of the toolbox.
All right, great. And a few questions getting back to yeast specifically when talking about fungi, because a lot of people want to know with the sugar, like if someone has,
Right.
let's say, candida overgrowth, should all sugar be avoided? Should they avoid fruit, or is it just minimize the
Great.
sugar consumption?
So again, I use a protocol that one of my mentors, Dr. Leibowitz, came up with like in the 80s, where we remove added sugars, we allow fresh or frozen fruit, stevia is fine. Sugar alcohols tend to aggravate GI symptoms, but it doesn't feed yeast per se. So I tell them to remove all added sugars, but fresh and frozen fruit are fine. Carbohydrates are fine, the healthy forms if they tolerate them. And that tends to work well. And patients would always ask, how about honey? How about maple syrup? So I have like a frequently asked question list. Just all of those still can make dysbiosis in any form worse and can negatively affect our health. So I think part of it is like a teaching tool of reading labels. I tell them, don't drive yourself crazy. If you're eating out, there might be some sugar in a dressing or something. Don't worry about it. Just when you're preparing your food, we don't want to add sugar. And that's kind of a long-term lifestyle change. I tell people, if you tolerate dark chocolate, the higher the percentage, the less the sugar. I think that's fine, like a couple grams of sugar here and there once we've gotten through the protocol. But while we're doing our first couple of weeks, I think it's really helpful for patients to see how they feel when they're not doing any processed added sugars outside of just fresh or frozen fruit.
Do you minimize the fresh and frozen fruits, like a couple of servings, or not
Yeah, I
necessarily?
tell them to use like reasonable judgment. So don't eat like 10 bananas a day, but a couple servings of fruit generally is tolerated and is fine. And unless they're doing something unusual, they're not eating like that much fruit. So I think a couple servings a day, if they ask, is totally fine for most people.
And how about fermented foods for yeast overgrowth?
Yeah, so for fermented foods, I have people do this old protocol that Sydney Baker came up with. It's a 5-day yeast mold elimination challenge diet. I tell patients these foods are not bad for you. They don't feed yeast, but you may react to them either because you're reactive to high histamine foods or because they are moldy. And so you can remove them for 5 days and then eat whatever of those you frequently eat. The most common are fermented vegetables, vinegar, those types of things, nutritional yeast. See how you feel. If you don't react, you don't need to remove them. If you do react, then we keep them out for the first few weeks of the protocol. And the other way I do it is, for some people, it's just easier to remove them for the first 2 to 3 weeks of our protocol and then add those back. And so we have kind of a more comprehensive list, but again, the main ones are fermented vegetables, vinegar, dried fruit, alcohol, sugar, yeast. The sugar we keep out for everyone. The other ones we only keep out if they're reacting, or if they just want to keep them out for the first couple of weeks because it's easier than doing that elimination challenge part.
All right. Can I ask you if you, I don't know if you know this off the top of your head, but approximately, like, what percentage would you say of your patient population have protozoa, like test positive for protozoa on Para-Wellness? And the same thing with fungi. And even if, I don't know if you want to include like molds, which,
Right.
but I guess, yeah, like,
Yeah.
So
It's always tricky because we have such a biased patient population because everyone has symptoms. So I would love to just have like 100 of these test kits to test 100 people in my community and see, because I'm sure my results are not representative of the general population, you know. But I would say of my patients, 80% have a protozoal infection. Of the Canada blood testing I do, at least 50% will show up positive for one of those that I mentioned. And again, those aren't definitive, but they're giving us puzzle pieces. So it's a very high percentage. And a lot of them have had SIBO testing done already. So that's often a piece of our overall landscape, but it's been done already. And probably at least 50% of them have had that imbalance. So I try to sort of orient what we're doing, that we're not, these are the three main pathogens or organisms that can be out of balance in the gut. And our overall goal is sort of to help make your system less likely to be having an overgrowth or infection of any of these, as well as eradicating protozoa and rebalancing those other microorganisms as part of our whole approach. But it's a very high percentage of patients that I test that have those.
And I know you have no affiliation with like Para-Wellness, but just what do you know what makes them? Is it just because that's what they focus on is parasites, and they've been doing it for a long time, that
Yeah,
makes it superior to other stool tests? Or
from what I've been told, the standard labs, talking about standard labs, not even our specialty, even our specialty labs, I think the training is not necessarily there as far as literally making the stool samples to look at under a microscope. And the director at Para-Wellness must have looked at tens of thousands by now of stool samples under the microscope. So it's a subjective skill in some ways to be able to pick out these organisms. It's the way it used to be done. But there were many lab changes over the last couple of decades where that's not the way that most labs are looking for protozoa anymore. They don't have a technician that's been trained for years on how to do this looking at a microscope. It's an antigen test, and it's an objective measure, which doesn't always correlate with the subjective looking under the microscope and having that skill set. So that's my understanding of why the prevalence is so much higher with that actual microscopy skill.
okay, very, very interesting. So is it just that one? Is it just that one technician there, or has he? I
I
would hope
don't
he
know,
trained others
actually,
too.
Eric. I don't know if he's got like a few. It seems like a large volume of specimens to look at. So I don't
Yeah.
know if there's a whole staff or what. At some point wanted to go and observe so I had the same question why, but it's panning out in the patient resolution of symptoms. So I know there are practitioners that question it. I would say just clinically it's made sense, and I don't see the intent. I have had patients have completely negative specimens, especially when I've had patients where they just say they're not having a lot of symptoms and they're just like, what else can we do? I have this autoimmune condition or this or that, and I just want to make sure, or there's family members. I have had fully negative test results at times, typically in patients that aren't manifesting any symptoms.
So you've seen like autoimmune cases where you address the protozoa, and if they have fungi, address the fungi, and then pretty much they get into remission by doing that.
Autoimmune is different, is it's usually not just those things. So it's this whole thing we're talking about, and it's stress, lifestyle, all of the things, that we talk about in integrative and functional medicine, where it's rare that I have someone that has sort of, it's so hard to dial in those other factors for all of us, even us as practitioners, that quote unquote, just fixing the microbiome is a huge feat in itself. And it can't get fully rebalanced without addressing all those areas. So yes, I have had patients with autoimmune conditions go into remission, but I can't recall a case when it was easy.
It's not just follow this parasite protocol. Yeah, I get it. It's
Right.
definitely,
And I've
definitely is complex. Yeah.
Yeah, I've had patients with alopecia areata where it did go into remission, but then it goes into remission on its own sometimes. So we can never, my patient and I thought it was from everything we did, but would it have gone into remission anyway? I don't know. But it did go into remission after we treated her protozoa. And she was someone who didn't have a lot of lifestyle factors that were impeding our progress. So really, it was a lot of gut stuff. And it was great to see her hair growth come back. We were both super excited, but yeah, was it what we did? Who knows?
Okay. Can I ask you one last question? Yeah. H. pylori. So you knew I wanted to ask you about H. pylori too. So what's your approach? Do you test for it? If someone is positive, do you treat it?
So I think the first thing to remember is I only want to test for it if someone has symptoms of H. pylori. I don't want to test for it just because they're having, for example, typical IBS symptoms, because so many people are sort of colonized with it worldwide and the treatment protocols can be pretty aggressive. So I only test for it if someone's having typical symptoms like reflux, epigastric pain, low stomach acid, and we're trying to dig into that particular symptom picture. And then if it is positive, so typically we use a stool antigen test, although there is urea breath testing. If someone's had an endoscopy, they'll have had biopsies for it. If it is positive, then we typically will treat it because we've usually done the test because they're symptomatic. I will have patients often ask about botanical options. The pharmaceutical options they are aggressive. It's, a proton pump inhibitor with a couple of antibiotics and bismuth sometimes. So I give patients both options. And if we're going to use a botanical option, I think it's definitely really important to retest and make sure we've eradicated it, because there are potential long-term consequences of untreated H. pylori in someone where it's causing symptoms. So there's a thorn product that I've used that has some of the things we've talked about, like berberine and bismuth. I think it's called Peptiguard. Most of the companies we use have some sort of H. pylori-like formula. So I think that option is totally fine as long as we're retesting to make sure we've treated it. And I have had patients where we've done the botanical program and it has been eradicated on retesting. So I definitely think it works for the right patient.
All right. Well, I know there's so much more we could talk about, but I do want to just ask, is there anything I should have asked you that I didn't ask you? Anything else that you want to talk about?
I feel like you touched on everything, Eric. I'll just say, in sort of 15, 20 years of seeing patients now, I find when I'm treating someone and we're sort of like getting into all of these details of that supplement or this supplement or why isn't this working, I found it really helpful to take a step back and again, make sure we're looking at those foundational pieces we talked about, as well as this whole histamine mast cell component and biofilm component. Those are the three areas where if we're getting stuck and spinning our wheels, there's usually something in those three areas that we've just sort of missed the boat on. And when I revisit those, that's where we can often find something that will work when we're just getting stuck in the older paradigm of just treating these bugs over and over again.
All right. Well, Dr. Ami, thank you so much for your time. And can you let others know where they can learn more about you?
Yes, thanks, Eric. So my website is amikapadia.com, just my name.com. And I have a resource tab that has a lot of the handouts I've made for patients and resources on there. And I see patients in Oregon. So if you live in Oregon or Southwest Washington, feel free to reach out to our clinic if you do need help. And thank you for having me.
Yeah, thank you so much. Of course, I'll put that website in the show notes. And it was a great conversation, and I'm sure the listeners learned a lot. And as usual, I learned a lot too.
Great. Thanks, Eric. It was nice talking with you.
Thanks, Ami.